All right, I'll go ahead and get started. Hello, everyone, and welcome to today's webinar entitled The Virtual Assessment of Lewy Body Dementia, Pandemic and Beyond. This is our third of our webinar series on the impact of COVID-19 in those with Lewy Body Dementia. This webinar and our webinar series is brought to you by our Lewy Body Dementia Association's Research Centers of Excellence. If you would like to learn more about our RCOE, please go to the lbda.org. I will be your moderator. I'm Dr. Katie Amadeo, and I am a movement disorder specialist at Westchester Medical Center in Poughkeepsie, New York. I also serve as co-chair for our RCOE working group on clinical care and professional education, along with our co-chair, Dr. Jennifer Goldman, who will be a panelist today. We're very excited. Next slide, please. So before I get started, just a few housekeeping notes. This activity is live and being recorded. You can find a recording of this within 2 weeks of today's session on our LBDA YouTube page, LBDA TV. And all the attendings as you come in, you are muted automatically, but we want to hear from you. So please, during the presentation, feel free to put questions that you have into our Q&A. I will be keeping track of that, and following our presentation by Dr. John Paul Taylor, we'll have a panel discussion, and I will try to get to all of your questions as best we can. And if we can't, don't worry, we're going to follow up with an email with frequently asked questions and answers to your questions. Next slide, please. So today's event, like I said, is brought to you by our LBDA Research Center of Excellence, our working group on clinical care and professional education, for which I serve as co-chair with Dr. Jennifer Goldman. Next slide. This activity today was supported by Acadia Pharmaceuticals, and we're grateful for that. Next slide. This is an accredited program, and we are offering, you will get 1 CME credit. We will follow up the presentation with an email on how to evaluate our program and claim that credit. Of course, it's free of charge to you. Next slide. As I said, it's available for 1 AMA CME credit. Next slide. And again, this is next slide. And these are our disclosures of our presenter and our panelists. Next slide. And so the agenda for today is we are so delighted to have Dr. John Paul Taylor with us today to present on this very now topic, and we'll follow this with a panel discussion. Next slide. And these are our objectives for today. So at the conclusion, we hope that you will come away with a better understanding of this data on a recent survey regarding the impact of COVID in the LBD population. Dr. John Paul Taylor is going to review LBD and its clinical features, what you should know and be aware of, and discuss why this population is particularly at risk for complications of COVID-19. And so, and next slide. I think we went there we go. And so without further delay, I will introduce our esteemed speaker, Dr. John Paul Taylor, who is the chair of Translational Dementia Research at Newcastle University. And again, we're so excited to have you speak with us today. Thank you so much.
Thank you. It's wonderful to be with you all. Good morning or good afternoon, depending on where you're at. So can we move to the next slide, please? So I will be speaking to you about the impact of COVID-19 in LBD. Next slide, please. So the outline of my presentation, first of all, is very much just a very gentle reminder of the diagnostic and clinical features of DOB. And then I'll move to the main meat of my presentation, which is really talking about COVID-19 and its impact in dementia with Lewy bodies. But as you will see as I go through my presentation, there is a real challenge in this space and a real dearth of data. So I have to draw upon what data there is within dementia and also Parkinson's disease to help inform the DOB situation and make some inference. Next slide, please. So I think it's important to make a disclaimer on this presentation. I'm UK based, so there's a UK flavor or perspective on what I'm going to present. I suppose the second thing is that, like many clinicians, we're all still non-experts in COVID-19. We really still don't understand this particular condition. So again, what I say now may turn out to be completely incorrect, within a couple of months or even a couple of years from now. So I may be putting 2 and 2 together and coming up with 5 is what I'm suggesting, and filling in the gaps. So I think we have to bear that in mind in terms of a caveat during this presentation. Next slide, please. So this is just, as I say, a gentle reminder for understanding DLB, dementia with Lewy bodies. There is the consensus paper of the diagnosis and management of DLB, which was published in 2017. It's a consensus report. It's freely available via Neurology. Next slide, please. And really, to sort of, before getting into that, I just wanted to very briefly say, and it's sort of an apology because I interchangeably use the term LBD and DLB, is that there is a bit of a diagnostic nomenclature to be aware of. Where we're sitting at the top, we have Lewy body disease, which then can manifest as Parkinson's disease, heading on to Parkinson's disease dementia, PDD, or dementia with Lewy bodies on the other side of the branches, as it were. And both PDD and DLB are essentially Lewy body dementia. Now, sorry, previous slide. In terms of LBD, and I think sort of considering Parkinson's disease dementia, it's somewhat of an arbitrary split between PDD and DLB, where Parkinson's disease dementia, the dementia starts 1 year or more after well-established Parkinson's disease, whereas in contrast in DLB, the dementia occurs before or concurrently with the Parkinsonism, or certainly within 1 year of the motor symptoms. But this is, as I say, is an arbitrary split. And indeed, we see a spectrum of people who have symptoms somewhere in the middle of this. So it can be quite difficult. And therefore, the catch-all term of Lewy body dementia is very helpful in this context. Next slide, please. So looking at the McKeith criteria, the consensus criteria from 2017, this is just to remind you of the core clinical features. There are 4 of them. There is motor Parkinsonism, and remember, motor Parkinsonism can be quite subtle or quite variable in people with DLB, often more of the akinetic rigid or postural instability form rather than tremor dominant. Complex visual hallucinations, typically of a biological phenomena, animals, children, people. REM sleep behavior disorder as a feature. This may be a symptom which antedates the onset of dementia with Lewy bodies by years or even decades. And then cognitive fluctuations, where one sees marked variations around a cognitive baseline. And it is really those large variations from being quite good to quite poor in terms of cognitive function, which really help typify this phenomena in dementia with Lewy bodies. Now, the criteria are quite straightforward. Sorry, previous slide. Probable DLB is a diagnosis where there's at least 2 or more of the core clinical features. Possible DLB is just 1 core clinical feature. Next slide, please. There are a number of core other sort of clinical diagnostic criteria. These lack the specificity of the core clinical features, but they certainly raise the suspicion of a diagnosis of DLB. Many of them, as you can see, relate to autonomic dysfunction, loss of sense of smell, increased daytime sleepiness, hallucinations in other modalities, and other neuropsychiatric symptoms, as well as a predilection towards neuroleptic or antipsychotic sensitivity. Next slide, please. Within the consensus criteria, there is also an awareness for the use of biomarkers in helping make a diagnosis of dementia with Lewy bodies. This includes the SPECT perfusion scans, sorry, not SPECT perfusion scans, previous slide. This may include the SPECT DAT scan, which takes a look at nigrostriatal degeneration. There's also other dopaminergic imaging available. We also have cardiac scintigraphy looking at the sympathetic innervation to the heart. And again, this is a deficit which appears to occur in alpha-synucleinopathies such as DLB and can help distinguish between DOB and Alzheimer's disease. In addition, we also can consider use of polysomnography as the gold standard for the diagnosis of REM sleep behavior disorder. Now, the presence of an indicative biomarker in conjunction with at least one clinical feature, one of the core clinical features, is sufficient to make a diagnosis of probable DOB. Next slide, please. There's also a number of supportive biomarkers, which again, similar to the supportive clinical features, don't have that same degree of specificity for DOB, but nonetheless may be useful in helping come to a diagnostic conclusion. These include taking a look at structural imaging scans, where one might see a less obvious atrophy of the hippocampus and mediotemporal lobe area. Sorry, previous slide. Apologies, these slides do seem to be moving quite quickly. And when we see this lack of atrophy, that might point towards someone who has got a diagnosis of DOB as opposed to Alzheimer's. There's also changes in terms of functional imaging, whether that's perfusion or metabolism, with a stereotypical pattern of a deficit more posterior in dementia with Lewy body patients, as well as also the cingulate island sign sparing. As I say, I'm not dwelling too much on the details of this. This is all covered within the consensus criteria. There's also EEG changes, typically a slowing posteriorly. Next slide, please. So, as perhaps what I'm alluding to, DOB is a complex multisystem disease. Patients can experience a range of symptoms: cognitive, neuropsychiatric, motor, autonomic, sleep. And we know that there's a heterogeneity in the expression of these symptoms between patients. And furthermore, there is a range of symptom severity fluctuation within individual patients and variations over time. And one of the other challenges that we face when the management is that when we help one symptom, this often leads to an exacerbation of worsening of another. For example, the use of dopaminergic medications leading to a worsening of psychosis, or antipsychotics leading out to a worsening of motor symptoms. Next slide, please. So this now comes to the main body of my presentation. And I think what I've been setting things up as is very much DOB is a condition with significant morbidity. And I think therefore in the context of COVID-19 is a condition one needs to be particularly aware of in terms of the consequences. So I did a very sort of quick and dirty literature search and looked at PubMed, looking at COVID-19 publications. And you can see, really, if you go on PubMed, there's a huge number of COVID-19 related publications. Interestingly, when you start drilling down to look at COVID-19 and including the search term dementia, you drop to around about 619 publications. If you include Lewy in the search term, it's just 19. If you look at COVID-19 and LBD as a focus, it comes to just 2. Now, I appreciate this is a little bit of a stretch, but if we're really looking at, has there been a focus looking at DOB and COVID-19 together, there is very few publications. Next slide, please. And this is just to highlight the 2 publications that I pulled out. And one of them's one which I'm going to be touching upon later, which was in relation to a practical paper looking at how one manages the COVID-19 challenges in people with DOB and also for the family members as well. Next slide, please. So where can we draw some of our ideas with the impact of COVID-19 and what to do about it in DOB? Well, let's look at dementia first of all. Next slide, please. There's clearly been issues with regard to COVID-19 and dementia. And this is an example of one of the papers in this space, which was a retrospective case control analysis looking at electronic health records in the US. And really to highlight the main take-home messages, the odds of having COVID-19 in people who have got dementia, whether you adjust for demographics or known COVID risk factors, or you just adjust for demographics, is about 2 to 3 times compared to people without dementia. So there's an increased risk of COVID-19. Furthermore, certain ethnic groups have a particularly high risk. And in addition, there is a high mortality between dementia and COVID-19, up to 20% over a 6-month risk period, with very high hospitalization rates. Interestingly, in this particular study, they were able to look at some subtypes of dementia, but you will notice that there is no frontotemporal dementia or indeed Lewy body dementia. Next slide, please. So this is a challenge. We don't know the impact, and the authors themselves highlight that they couldn't examine DOB or LBD due to insufficient sample sizes, and that's because the diagnosis isn't noted that often. They did control for nursing home stay, which is something I'm going to touch upon later, but certainly the risks for getting COVID-19 they felt were related to a number of latent factors. Perhaps the cognitive impairment limiting compliance with social distancing, mask wearing or hand washing. Or indeed the question is whether dementia is a state which has naturally got an increased susceptibility to SARS-CoV-2 infection. Next slide, please. Now, speaking to nursing homes, I think that, at the moment in the UK, where there's a great deal of political angst, as there's a recognition that what happened is that a lot of patients got discharged from secondary care back to nursing home or care homes with undiagnosed COVID. And we know that nursing homes have been epicenters of COVID-19 infection and COVID spread. And indeed, the presence of dementia in nursing homes does lead to increased risk of death. And indeed, residents with dementia accounted for over half of all COVID-19 cases, and indeed very high rates of deaths. Next slide, please. Looking to COVID-19 and Parkinson's disease is another way to give an idea into the impact of COVID-19 and DOB. I appreciate it's not the same thing, but I think it's a helpful perspective. Next slide. So from this particular direction of travel, there's certainly coming quite clear that the risk of COVID-19 is associated with increased age and frailty in people with Parkinson's disease. There's also increased risk if there's a presence of comorbidities, such as cardiovascular disease, obesity, diabetes, any pre-existing pulmonary disease, being male, coming back to that point of being a nursing home resident. Notably, vitamin D supplementation has, in a number of studies with Parkinson's patients, been associated with lower cases of COVID-19, although these are non-randomized studies which have been amalgamated. But overall, you're probably seeing here that these risks are risks which are quite similar to the general population. Next slide, please. In terms of the median infection prevalence, it's dependent upon studies, and when systematic reviews have looked at this, it's varied from 0.6% to 8.5%. It is sort of affecting the older person with Parkinson's, but what is noticeable is that up to a third of patients require hospital admission with Parkinson's disease who get COVID-19. There's also evidence that there's been changes or dose increases in levodopa, and a significant mortality of just under 20%, so 1 in 5. And that's quite similar to the statistics which are coming out from dementia. And remember that the case mortality rates for COVID-19 are estimated to be 1 to 2% in the overall population. Next slide, please. When you get COVID-19 and you end up in hospital with Parkinson's disease, you're more likely to have more severe COVID-19, and you're also more likely to die. Now, in analyses so far, these outcomes have been influenced by age, but not necessarily gender or dementia, interestingly. Next slide, please. If you get COVID-19 and Parkinson's, there does appear to be a worsening of motor symptoms in a substantive minority of Parkinson's patients. There's also worsening of non-motor symptoms. These tend to be anxiety, sleep, emotional status. Various explanations have been put forward for this, including the social isolation, lack of exercise, reduced face-to-face contact with clinical team. And again, these things are something I'm going to pick up on later when I discuss our DOB survey. Next slide, please. Now, perhaps a slightly more positive message from a vaccination point of view. A number of studies have looked at the incidence of side effects in Parkinson's disease, and these don't seem to be any different compared to the general population. Furthermore, having the vaccine or any one of the vaccines doesn't appear to affect Parkinson's therapeutics. There is perhaps a slight concern if you are vaccinating frail elderly people, particularly those living in long-term care facilities, that you might just need to be a little bit extra cautious. And this probably translates across to people with DOB or LBD. Next slide, please. Okay, so I've really danced around it, haven't I, and not really addressed COVID-19 and DOB, and that really reflects the dearth of data which is out there. So let's try and see what we can look at. Next slide, please. Now, in the UK, it was quite interesting that we had an approach at the height of the pandemic of consideration of how we would allow our patients to access critical care or ICU beds. And various algorithms were put forward to decide on this. Interesting, one of the things was with regard to frailty, and the clinical frailty score was one scale which was used to help inform these decisions. Now, I appreciate it's probably quite small on your screen, but essentially scoring on these scales is predicated on the basis of how much functional impairment you have, medical comorbidity, and cognitive impairment. And you can already see that somebody who's got DOB is probably going to hit all three of those buttons, as it were. So I think intrinsically, people with DOB during the pandemic were probably biased against having more intensive care in hospital if they had COVID-19. Next slide, please. The other thing which I highlighted in the dementia section was the issues with regard to nursing homes. Nursing home residents being highly vulnerable to the spread of COVID-19 and having a high mortality as a result of this virus. Sort of again, this is a bit of an intimation, but various studies have certainly suggested that DOB people living with DOB are overrepresented in nursing homes. This one Swedish study, for example, finding 16% of residents had 2 or more core symptoms of DOB, rising to 20% if you considered any Parkinsonism, which was included. So I think very much, again, sitting within the community, DOB, people with DOB are likely to be at high risk of getting COVID-19, with then the significant morbidity and mortality sequelae. Next slide, please. People with DOB are at increased risk of bronchopneumonia. We know that they have problems with swallowing, with coordination of their pharynx. There's also a failure to notice and report symptoms due to cognitive impairment, which is synonymous with all the other types of dementias. Also issues with adhering to social distancing, mask wearing due to cognitive impairment. And then lack of face-to-face contact, either with professionals or family, due to the lockdown isolation, leading to progression of symptoms. And I think one of the other final points is that we know that people who have got DOB are at increased risk of developing delirium, regardless of the cause, compared to other dementias. And delirium in itself appears to be now a neurotoxic state, which is an accelerant to neurodegeneration and cognitive decline. So getting COVID-19 and getting delirium and having DOB is probably not a good combination. Next slide, please. I've spoken to you about the social isolation with cognitive impairment, and I think again this is also salient in our DOB group, particularly with regard to variability and adherence with medications. Many of our patients are on multiple tablets and pills, and particularly if they're managing their Parkinsonian symptoms, we know that these are time specific, and I think this has been very challenging for a lot of our patients. Furthermore, lack of contact has often led to concerns with regard to hydration or eating adequately. And furthermore, the lack of exercise in our populations increasing the risk of muscle atrophy, sarcopenia, and falls. And we know falls anyway are a significant risk for Lewy body dementia. Next slide, please. The lack of social contact, potentially exacerbating hallucinations, worsening of fluctuations, and leading to apathy. The isolation also exacerbating delusional ideas, and certainly anecdotally, this is something which I've been seeing in the clinic more recently. And indeed, people are not understanding the situation, which is then contributing to affective symptoms and agitation. A further thing which has come out from anecdote is challenges with the communication that we are now having to operate in this virtual world. As a result of executive impairment, visual perceptual dysfunction, sometimes people are incorporating what's on the screen into their delusions and hallucinations. And that can be really challenging when one's trying to have a dialogue as a healthcare professional, or indeed the interactions between friends and family. Next slide, please. The other thing which we need to be cognizant to is that we know that there's a higher baseline caregiver burden and depression for caregivers and family who have somebody with DLB. And that was there before the pandemic, and undoubtedly with the COVID era, this is going to be exacerbated. There's been the closure of day centres, lack of overnight respite, loss of formal or professional caregivers. And I think also we need to be aware of the COVID-19 risk issues for caregivers themselves, who are often carrying their own comorbidities. Next slide, please. So I think that's certainly I suppose a perspective from first principles, but have we got any meaningful data to perhaps underwrite some of those statements that I've made? Well, in the UK, we conducted with the Lewy Body Society a survey of people who are living with DLB and their families and caregivers. This work was led by Alison Killen, and we promoted this particular survey in the LBS newsletter, on social media, and also via contact via a system that they have there as part of what we call a Admiral Nurse facility, which allows communication and a helpline effectively on the telephone. It ran for 5 weeks in January to February of this year, and we got a pretty good response. Now, we recognize that the majority of responses are going to come from caregivers, but we asked caregivers to respond on behalf of the care recipient and to give the person who was living with DLB their perspective rather than the caregiver perspective. So it's essentially a sample of community dwelling people with DLB or LBD. Next slide, please. So this is a bit of a word cloud to really sort of capture some of the free text comments. I think it doesn't take very much to titrate down the key messages. Being not able to see family, social isolation, lack of contact. These are the main messages which were coming out. Next slide, please. So looking at more sort of specific questions which were posed, what was evident is that people felt that they weren't able to do the usual forms of their exercise. They were spending less time with friends and family. They were instead, if they were going to have contact, this was going to be by telephone or other means, and very few of them took up any new activities. So the ability to access social support and leisure activities were severely constrained in the COVID period. Next slide, please. Now, this is quite busy, but just really to again titrate it down for you, this is access to health services, whether this was at the primary care level, secondary care level, specialist service. And really overall, there was a majority experienced some form of disruption. Many had cancelled appointments. Many of them had reduced contact with specialist services. There was greater use of the virtual means, and I know this has been a topic of discussion in the previous sessions, use of telephone and video calls to try and maintain some form of health service contact. But a lot find this incredibly challenging. Next slide, please. So what the people say was the impact for them. I think there's significant effects on mood, with up to 3/4 saying that their mood had been low to an extent which was unusual for them. These are just some boxes highlighting some of the comments that we received. For example, my husband's mood has deteriorated to such an extent he has suicidal thoughts and made a feeble attempt of throwing himself down a small flight of stairs. Feeling depressed is not being able to go out as usual. Find it difficult to wear a mask, keep wanting to take it off. It's also difficult to understand what others are saying. It's very confusing. Next slide, please. Memory problems had also worsened as well, and indeed up to 90%. Now, you may argue that this is perhaps an inevitable aspect of the condition, but I think certainly this represents an accentuation of what we might normally see. And along with memory problems getting worse, mobility was also described as being affected as well. And I think a lot of this had bearing or association with the lack of family contact and social isolation, and struggling then to operate, as I say, in this virtual world and understand the rules of lockdown, and as one individual is highlighting here. Next slide, please. Hallucinations were also described as becoming more frequent and severe, up to probably just over 3/4. Fear triggered start of hallucinations, beginning with hallucination of the government COVID meeting taking place in the living room and being obliged to attend. Increased hallucinations with loneliness, going into hospital, the inability of relatives to visit, had to be reminded every day about COVID, struggling with the wearing of masks. And again, this is certainly something that we picked up an anecdote that people with DOB, given their visual perceptual and executive problems, struggle then to, they already have an issue trying to interpret the visual scenes, the visual gestures and emotions, and undoubtedly wearing masks probably impairs that further. Next slide, please. Was there any positives? Well, there was a few positives which came out of the survey. Some people had increased their daily exercise. They were making use of supermarket delivery. They also found out that there was actually quite a caring network around them. For example, neighbors. One person highlighted that they liked the fact that there was less noise from traffic and planes. And indeed, the fact that many people had to remain off work and were working from home meant actually that in some cases there was actually greater contact for some individuals. And I think, so that's perhaps some of the messages in terms of some of the positives. But overall, unfortunately, the positives were outweighed by quite a lot of the negatives. Next slide, please. Now, this is not, as I say, this is a survey, so we haven't got hard statistics on this, and this is a bit of a guesstimate. But we asked whether people had COVID, and certainly 10 out of the 87 indicated a positive test result. Another 5 had symptoms that they sounded like COVID, although they were not formally tested. So we made a rough estimate that about 17% of people with LBD had caught COVID-19. Next slide, please. The duration of the COVID symptoms of those who had the symptomatology was probably in the typical range of 2 to 4 weeks, maybe some having a little bit longer. Next slide, please. In those who got COVID-19, we asked about change in symptoms since having it. And again, really it's a busy slide here, but to just give you the take-home messages, about 1/3 to half of people with DOB have worsening across the majority of symptom domains as a consequence of having COVID. Next slide, please. Now, I think there's enormous limitations on this survey. Clearly, it's a UK context. Many of the surveys were, as I say, at the start were completed or supported by caregivers, and that may introduce an intrinsic bias. Furthermore, these were probably individuals who were less severely affected. We were not capturing those individuals who were ending up in hospital, for example. Furthermore, as we know, engaging with technology, particularly an online survey, that does lead to a non-representative sample. And we had no idea whether people had a definitive diagnosis of LBD. And of course, information that you can collect online is often limited. Next slide, please. So this heads into the final section of my talk, and indeed probably the more speculative end of things. And that's really sort of asking about COVID-19 and direct brain effects. Next slide, please. Now, as I say, there's no particular literature on LBD in regard to COVID-19 in this space, but Patrick Brunden and colleagues produced this nice commentary paper really looking at the SARS-CoV-2 infection and its potential impact and how COVID-19 then leads to potentially vascular damage, systemic inflammation, or indeed direct neuroinvasion, with the concept of potentially there is an acute phase where one might have microglial activation, T-cell infiltration, indeed alpha-synuclein upregulation. There's certainly preclinical models which have suggested that alpha-synuclein might be actually a protective feature against certain viral infections, and indeed upregulating alpha-synuclein may be a normal response to viral infections. But beyond the acute, then what is the sort of longer term consequences? If you have these acute changes, do they then lead to a predilection towards alpha-synucleinopathies in the future, alpha-synuclein aggregation? And I think there's a lot of unanswered questions in this particular space. I think, you know, I suppose one of the positives is certainly that there hasn't been an excess expression of Parkinsonism. I think Jennifer, afterwards, when we have the discussion, might be able to qualify more. But certainly there has only been a limited number of case reports that I've been aware of where there's been an acute COVID-19 episode, which has then led to subsequent Parkinsonism. Next slide, please. So how could SARS-CoV-2 lead to the direct brain effects? Well, it has to get into the brain, and I think one of the routes in potentially is via the olfactory system. We know that people who get COVID-19 complain of anosmia or hyponosmia, and then that's really in regard to the binding to the ACE2 receptors within the basal cells within the olfactory system. And interesting, I suppose, that in a way recapitulates some of the arguments that in alpha-synucleinopathy, such as LBD, there may be a olfactory to brain spread, as it were. Another mechanism is potentially through the respiratory system. So again, we know clearly COVID-19 is predominantly within the respiratory system. So therefore, the SARS-CoV-2 virus can get into the bloodstream and then spread to the brain, potentially, if we look at number 4 here, as a result of changes in blood-brain permeability as a consequence of systemic infection, and that being a mechanism then. The other route in is the enteric system, again, the virus coming in that direction and then being passed through the vagal nerve and then from the vagal nerve to the brain. And again, I suppose that does in a way sort of recapitulate some of the ideas which people are expressing with regard to alpha-synuclein seeding within the periphery and then going centrally. Next slide, please. So what's the hard data? I've spoken a little bit about some case reports with regard to Parkinsonism and COVID-19. I think it's still a little bit unclear at the moment, but you know, there's been a number of different surveys looking at neurological and neuropsychiatric complications. And we do know that COVID-19 does cause a lot of problems. Indeed, between 20 and 30% of hospitalized COVID-19 patients probably have some neurological or neuropsychiatric complication. Now, in the older age group, this predominantly seems to be cerebrovascular events, and that probably relates to the tendency to coagulopathy, which is associated with COVID-19. So ischemic stroke. There's also evidence for intracerebral hemorrhages, vasculitis. And then in younger patients, there's also clearly the potential for other things, psychosis, encephalitis, and encephalopathy. So I think the message is that, yes, COVID-19 does appear to have a number of very significant neurological and neuropsychiatric sequelae. How that relates to alpha-synucleinopathy, I think, remains to be seen. Next slide, please. I've also, I suppose, hinted at with regard to Patrick Brunden's diagram that there is this longer-term effect of COVID, and we are seeing a number of people who are experiencing so-called long COVID. And there's a wide panoply of symptoms in this condition where people are still experiencing respiratory difficulties, joint pain, tinnitus, anosmia, palpitations, sleep disturbance, in particular severe fatigue, as well as neuropsychiatric symptoms. And I think very notably this idea of brain fog. But what is this, and how does this relate to long-term psychiatric and neurological symptoms is not clear. There is an ongoing study in the UK, COVID-CNS, which is going to be looking at people who have more severe disease, hospitalization with COVID-19, and what are the long-term sequelae. But again, I think only time will tell to really unpick where we're going with COVID-19 in this space. Next slide, please. Now, I'm coming back a little bit to some of the theoretical concerns with regard to alpha-synucleinopathies and Parkinsonism and LBD. We're all very aware of, following the Spanish flu pandemic in 1917-18, that there was then this epidemic of encephalitis lethargica, and that's obviously been very famously characterized in Oliver Sacks' Awakenings. So, I suppose the fear is that maybe something similar might arise subsequent to the COVID-19 pandemic. There's also data to suggest that we see antibodies against coronaviruses in the CSF of patients with Parkinson's disease. That might intimate a relationship between both entities. Next slide, please. Now, some of you may have seen this more recent preclinical paper. It's not quite out yet, where SARS-CoV-2 causes brain inflammation and induces Lewy body formation in macaque monkeys. And they noted that there was infiltration of T cells in the brain parenchyma, and they were arguing that there was altered blood-brain barrier integrity, and also access perhaps via neuronal pathways via ACE2 receptors. And they were able to demonstrate viral RNA positive regions in the brain, activated microglia, as well as Lewy bodies, although I know some of my basic science colleagues have challenged somewhat whether these are true Lewy bodies or not. But I think we have to be aware that certainly some of the coronaviruses do have this tendency towards perhaps formation of Lewy bodies and perhaps the risk of future Parkinsonism. We really don't know. Next slide, please. Looking at postmortems of people who have died as a result of COVID-19, there is evidence of neuropathology in the brains of older individuals. However, I suppose in a way, this is the neuropathology which was seen is probably in keeping with the age of the population. So it's not atypical. Next slide, please. What was evident is that there's lots of hypoxic or ischemic changes in brain regions, evidence of infarcts, also hemorrhages. There is perhaps some microglial activation, predominantly the brainstem. We don't know the significance of this. But overall, there doesn't seem to be very much viral RNA within the brain parenchyma, and certainly no correlation with histopathology. So maybe it's not so much the direct viral infection of the brain, but instead the systemic inflammation and those processes which are giving rise to the challenges, as well as the coagulopathy, and giving rise to this sort of picture of brain change. Next slide, please. Now, I'm nearly finished now. I think this is probably just a point to make and really to signpost. We do use a number of drugs in LBD, which might interact with some of the acute COVID-19 treatments. I'm not going to go through these in detail, but just really to highlight that the Movement Disorder Society have produced a nice webinar on this, detailing this. And I would certainly suggest you look there if you're sort of thinking about how do we manage our Parkinson's and Lewy body dementia patients in regard to some of the acute COVID-19 treatments. And I think just final point, cold and flu, and sorry, flu is spelled wrong here, remedies can, of course, as we well know, interact with monoamine B inhibitors, although many of our LBD patients aren't on these agents. Next slide, please. So just to sort of conclude, I think there's a likely increased risk of exposure to COVID-19 and increased disease severity in LBD, DOB. It's still unclear is the direct effect of COVID-19 on LBD. I would probably argue that actually there's profound indirect impacts as a result of the pandemic on day-to-day function and mood in people living with LBD. And this reduced healthcare contact, which we have seen, and indeed now we're certainly in my clinic, facing a bit of a tsunami of problems and issues because patients haven't been able to be seen. And I think this is probably going to bring significant risks to people and their families living with DOB. Next slide, please. So I'm just going to finish on one final slide. This is again from a UK context, but I'm sure it's applicable to the US. And there's been profound impacts of COVID-19 on dementia research. 95% of researchers in this one survey had projects or trials delayed because of COVID-19. 1 in 5 have research projects cancelled completely. And certainly I would hold my own hand up and say I was one of those 5. And furthermore, research leaders aren't resuming the same levels of activity at their labs as they were before. And indeed, many still haven't returned to their workplaces. So I think there will be a long-term sequelae of COVID-19 on dementia research going forward. And I think, the LBDA and other policy influencers, I think, have their role to play to really push hard that we don't face a huge dearth in dementia research going forward. Thank you very much.
Thank you so much. That was excellent. Yeah, that was great. So we will now move to our panel discussion, and thank you for those who have asked questions. Please keep the questions coming as we go. So I think we have a lot to discuss in terms of how the impact of COVID on Lewy body dementia, but I think perhaps we get there. We did have 2 questions on clarifying some terminology and diagnosis that we'll take a step back and we'll answer those first. And so I'm going to pose, I think, the first question actually to Dr. Jennifer Goldman. We often get, I think, a lot of questions about terminology in our various webinars and so forth. And so, I think families have struggled with this, our patients, as well as clinicians. And so I was wondering if you could speak a little bit more about what we mean by Lewy body dementia versus DLB, dementia with Lewy bodies, versus Parkinson's disease, and when we say Lewy body dementia, what do we mean by that? Oh, sorry, Jennifer, we can't hear you. Yeah.
Okay. Can you hear me now?
Yes.
Excellent. Wonderful. Well, thank you so much for inviting me to be a panelist today, and to John Paul for a fabulous talk. Really wonderful. So Lewy body dementia probably can be best thought of as an umbrella term that encompasses underneath that umbrella two defined conditions, if you will: dementia with Lewy bodies and Parkinson's disease with dementia. So it's correct to still say Lewy body dementia that covers both of those entities, which I think can sometimes be a source of confusion for people, not only patients and their families, but among healthcare professionals when trying to speak the same language. Going back to the consensus criteria that have been developed over several decades, that 1-year rule that has been mentioned has still been applicable. And I think probably the way to think about it would be if someone starts with more typical Parkinson's motor features and then later over the course of years develops dementia, that would fall more typically under a Parkinson's disease with dementia. Whereas if someone has more significant cognitive disturbance or dementia early, may or may not have a little bit of Parkinsonism, but may have some of the other features that Dr. Taylor mentioned, would fall more under that dementia with Lewy bodies category. Now, we know that people don't always fall into the boxes that we try to just place them into for definitions and so forth, and we recognize that mild cognitive impairment can be present in Parkinson's disease early on, And we know that dementia with Lewy body patients can have a whole host of symptoms, including Parkinsonism, and that often those lines are very blurry. But perhaps that might give some consistency to various terminology that's used.
Thank you so much. And this question is for Dr. John Paul Taylor. You know, we talk about the different biomarkers in the diagnostic criteria and so forth. And so we had a question about whether the DAT scan is required for diagnosis of LBD or DLB, and is the administration of tools like the MDS-UPDRS, is that needed to make a diagnosis of Parkinsonism?
Yeah, really good questions. I think what is nice with the consensus criteria is that it can be done on clinical alone. So if you've got 2 or more core symptoms, then that's sufficient to meet a diagnosis of probable DLB. And we know that that's got a pretty good conversion then when we look at postmortems to the presence of a Lewy body pathology. The DAT scan is a very strong biomarker. It's an indicative biomarker, and certainly, you know, if you've got one of the core symptoms and you've got a positive DAT scan, that then makes you pretty, you know, you can be fairly confident that this may be a probable dementia with Lewy bodies. I think some of the data which has come out with the DAT scan is that it probably is better when one takes a look at neuropathology. So it tracks the neuropathology better, so it's more accurate than clinical diagnosis alone. But I certainly, you know, I think if, you know, like all of these biomarker tests, I would certainly only use them where you're in more of those areas of uncertainty. So if you're already beginning with a prior sort of a probability of DLB of, let's say, 80%, and you're saying, well, I'm going to do a DAT scan, which is 85%, you're only sort of increasing things by about 5% for, you know, what's quite an intensive and expensive test. If you're more 50%, then, you know, clearly getting up to 85% with the sensitivity specificity of the DAT scan is a good thing. So that's the way I sort of crudely look at it.
Thank you. Thank you. And perhaps, Dr. Goldman, you could speak a little bit about, you know, the MDS-UPDRS in making the, it's okay. And you can too, Dr. Phil, if you want to add, but that was excellent for the DAT scan. But do you need that when you're making your diagnosis? And I know we've talked a little bit about how the challenge of that, particularly with remote visits. So I just want to hear a little bit about what you think.
Sure. And it's really a clinical diagnosis of Parkinsonism on the motor features. So actually it is not defined how one would need to measure those. So I will say that the criteria are fairly broad. They don't specify that you need to do a UPDRS or the more recent version, the MDS-UPDRS, but anchored within that is some definition of bradykinesia and other motor Parkinsonian features. So to drill down, how does one then make that assessment and need to measure it? So, you know, as a movement disorder neurologist, the UPDRS or MDS-UPDRS is kind of a staple of what I do every day when I see patients in clinic, and it's, you know, relatively easy to administer to be able to get a sense of what is true bradykinesia or rigidity or postural instability and tremor and so forth. So although not specified, it would be a useful tool to be able to capture those Parkinsonian features and helps people kind of talk the same language too when we talk about definitions and meeting criteria. We did talk about how it's a little bit challenging to administer some of these over telehealth, but motor assessments actually can be done in the setting of telehealth. The one challenge we've had particularly is rigidity, testing for that, and then testing by using the pull test, but there are other proxies for postural instability.
Thank you. I had a question for you, Dr. Taylor, about why hallucinate, your thoughts on why hallucinations may be increased in that survey among our patients. Now, I know obviously some were accounted for by having the infection themselves, having the infection, but what are your other thoughts for those, maybe that aren't infected but had an increase in hallucination?
And that's a very good question. There's probably not much research evidence for this, but there's more evidence, I suppose, on clinical anecdote that people with LBD, if you are in a sort of a novel social environment, you tend to be less confused, you tend to hallucinate a lot less. But if you're in your own environment, and I think I'll use the word here, where things are a little bit boring and things aren't changing and are more stereotypical, these are often perhaps the trigger points, and perhaps first of all influencing the cognitive levels, the cognitive fluctuations, and then also being a more stereotypical environment, perhaps acting as triggers or cues for the hallucination formation. Remember, a lot of the hallucinations are very prosaic. They're often of family members or cats or dogs, which are coming into the living room or whatever. So I do wonder at the lack of social contact, that isolation drives some of this. Social isolation and boredom drives it, the hallucination manifestation.
Brilliant, yeah. And I even what you said about the masks, I think is really important too. Dr. Goldman, I wanted to ask, because we know, socialization is so important as we talk about neuroprotectiveness, and then we see the impacts in our patients, as Dr. Taylor pointed out in his survey. How are you approaching this with patients and loved ones, or what recommendations were you saying in order to stay cognitively engaged but safely?
Oh, that's such a great question, and so important, because the impact not only physically but on mental health from the pandemic is huge. Has been huge, and we've seen it in our patient populations that we serve. So, a number of ideas on that front, and I'm sure there are many more out there, but we've pivoted quite a bit to online platforms to keep people engaged with educational programs, support groups, sessions and seminars, including ones through LBDA and other organizations, to keep people in touch and engaged. So that could be one way. And some of those even include exercise classes, things people can do in their homes, mindfulness classes or stress reduction classes and sessions. And that can help to some degree. I think we tried to promote people having contact with other family members, whether that's, knowing someone who can check in with them regularly, even virtually. And I will say that's one silver lining of, doing some telehealth is we've been able to reach family members to come into visits from far parts of the country to increase that social engagement and presence in an appointment setting. And I think, we're starting to see some changes as the pandemic has evolved, with people becoming a little bit more social in person, albeit safely, and just, increasing that awareness to keep people active, engaged cognitively, and so forth.
Thank you so much. Thank you both so much. This does wrap up our panel, but we will be sending out answers to questions that we weren't able to get to via an email. So thank you both so much. And Angela, please take away our conclusion.
All right, thank you all. So grateful to have had all three of you on today's event. To our viewers, we want to just let you know that there's a follow-up email that will be coming to you shortly. Please complete the evaluation, and then you will be able to download your CME certificate or save it on your computer. This is not the only CME activity we have. There is currently one on Medscape right now that was a collaboration between Medscape and LBDA, so please do check that out. And we hope to have more of those collaborations coming soon. So please watch your inbox as those are ready for release. And just a note about our Research Centers of Excellence program. This consists of 26 of our nation's leading LBD clinics, and this is a great place for LBD families to turn for advanced diagnostic care and clinical care. keep us on track with our time. Just one last slide about LBDA. Our mission really is through outreach, education, and research. We support those affected by Lewy body dementias, their families, and caregivers. So we please encourage you to go to lbda.org to learn more about the disease, resources we have for families, and to continue to stay up to date on research. This is the end of our event today. We'd like to say thank you again and hope that you have a very nice day.
Thank you.
Thank you very much.